So today we're diving into one of the most confusing and controversial topics in women's health, hormone therapy. It's going to be a long one, so I thought I'd give you a PowerPoint to hopefully help supplement and drive home some key points. You will sometimes hear hormone therapy referred to as HRT for hormone replacement therapy, BHRT for bioidentical hormone replacement therapy, and then MHT for menopausal hormone therapy. There are some slight differences, but essentially people are referring to the same thing. So why would you consider even taking hormones if menopause is a natural part of life? Of course, there are some symptoms of menopause many of us already know about, like hot flashes, night sweats, low libido, vaginal dryness, urinary incontinence. Now, you might say, Tanya, I didn't have a rough transition. I didn't have too many symptoms, or I think I'm past all that and I don't have hot flashes anymore. Do I even need hormones? Well, hormones are really what gives us vitality and that feeling of youthfulness. They affect every system in our body, which in turn affects the quality of our life. It affects our mood, our motivation, our energy, our strength, our metabolism, our sleep, our ability to think clearly, our memory. A common thing I see happen in women is that they have a hard time with memory recall, with nouns like, what do you call that thing again? Or a few years after menopause, they start complaining about fatigue and needing to take naps in the afternoon. Energy is not the same. Or they started gaining weight, or they're pre-diabetic now. Their cholesterol is going up. Now they have hypertension. Now your doctor is prescribing you a bunch of meds. You didn't change your lifestyle, so why is this happening? Well, your hormones changed. We will talk more in depth about this in another video, but these are just some of the other things worth considering. Now, if you've Googled hormone therapy before or seen this on social media, you've probably seen everything from hormones will save your life to hormones will kill you. No wonder so many women feel stuck and scared. My goal with this lesson is to simply help you finally understand the truth, what the research actually says, what it doesn't say, and why hormone therapy today is very different from what was being prescribed 20 years ago. Here's the bottom line up front. Hormone therapy is very safe, and it is the most effective treatment we have for hot flashes, night sweats, and other menopause symptoms. There's a lot of benefit for preventing chronic disease and preserving your quality of life. But like anything in medicine, the details matter. The type of hormone, the dose, how you take it, and when you start. If it's so beneficial, why are doctors not prescribing it? Well, I'm glad you asked. Let's rewind back to the 1980s and 1990s when hormone therapy was everywhere. It was one of the most commonly prescribed treatments in medicine. In fact, around the year 2000, about 1 in 3 menopausal women in the US were on hormone therapy. Doctors thought it not only helped symptoms, but also protected against heart disease, bone loss, and even dementia. The NIH wanted to test those big promises, so they launched the Women's Health Initiative, or what we call the WHI, in the early 1990s. It was the largest hormone therapy trial ever done. The purpose of this study wasn't to see if hormones helped with hot flashes or sleep, because we already know that it does. It was designed to see if hormones could prevent chronic diseases like heart disease, cancer, and fractures in older women. In 2002, the WHI was stopped early when preliminary reports came out falsely suggesting that hormones cause breast cancer, which really was the most damaging in women's health. The media headlines were terrifying. Hormones cause breast cancer, hormones increase risk of heart disease. Practically overnight, prescriptions dropped by 80%. This put a lot of fear in prescribers. Women were told to stop their hormones immediately. This damage lasted decades to come. Even now, doctors and patients hear or believe that hormones cause cancer. Now, only about 4% of women who qualify for HRT are reported to be using it. And now, most doctors nowadays aren't even taught how to appropriately prescribe HRT and treat menopausal women. Now, here's where we need to slow down and talk about the actual details of this study. The WHI didn't study all hormone therapy for all women. What I mean by that is there are different forms of hormones like transdermal or bioidentical, which we will dive into later, but it studied two specific pill regimens. For women with a uterus, a pill called Prempro, which is a combination of oral conjugated estrogen, basically from horse urine, plus a synthetic progestin called medroxyprogesterone acetate, or MPA for short. For women without a uterus, just the oral conjugated estrogen pill, CEE, no progesterone or progestin was prescribed. This is because if a woman has a uterus, you must have progesterone. If you don't, you are in increased risk for uterine cancer. But if you have had a hysterectomy, obviously you can't get uterine cancer. So you don't need technically progesterone for that reason. Remember, I mentioned earlier that the purpose of the trial was actually to evaluate for the prevention of chronic disease. That being said, the average age of women in this trial was actually 63 years old. That is a full 10 to 12 years past menopause. Most were well beyond the stage where you and I are talking about symptoms like hot flashes, night sweats, and weight gain. If women were experiencing hot flashes, night sweats, weight gain, then they would know whether or not they were on hormone replacement therapy because they would feel the difference. So let's dive into the scary finding everyone remembers. In the group taking estrogen plus MPA, the synthetic progestin, there was an increased risk of breast cancer. But here's what often gets lost. So try to follow this. The relative risk, meaning the group with both hormones versus the group with just estrogen, the increased risk was statistically significant, yes. But in real numbers, I'm talking about absolute risk, meaning compared to the average woman who isn't taking hormones at all, it was small and not statistically significant. What does that mean? It worked out to about 8 extra cases of breast cancer per 10,000 women per year. Let me put that another way. If you lined up 10,000 women, like the ones in the WHI study, about 38 would get breast cancer in a given year without hormones. With that specific pill combo, oral horse estrogen plus synthetic progestin, it went up to 46. That's 8 more women out of 10,000. Now, I'm not saying risk doesn't matter, but it's important to see the scale. The headlines made it sound like every woman who took hormones was doomed, and that simply wasn't true. Here's the part that never made the news. The women who only took estrogen because they didn't have a uterus actually had a lower risk of breast cancer compared to women on placebo, not higher, they had lower risk. And in long-term follow-up studies, they also saw that they had lower breast cancer mortality, meaning the women on estrogen who got breast cancer had a better outcome. Even with the horse estrogen, which nowadays we mostly use bioidentical estrogen, it was still protective. So the scary result was really about the one combination, horse-derived oral estrogen plus the synthetic progestin, MPA, not about estrogen itself. Not about modern therapies like transdermal estradiol with micronized progesterone. So here's what's missing. The WHI didn't study younger women in their 40s and 50s who are just entering menopause. It didn't study estrogen patches, gels, or sprays, which research suggests are safer for clotting risk compared to pills. And it didn't study bioidentical progesterone, the form that chemically is identical to what your body makes. Other research since then, like the E3N study in France, that looked at 80,000 women, had shown that there is no increased risk of breast cancer when women used estradiol with bioidentical progesterone. And this is really important. Later trials like KEEPS and ELITE looked at women closer to the menopause transition, and they found that starting hormones earlier, not decades later, didn't carry the same risks and may even have cardiovascular benefits. This is where the 10-year window hypothesis comes from. The earlier you start after menopause, the safer and more effective it seems to be. So here's the takeaway from this. The bad is that the WHI caused fear that still lingers today. Millions of women stopped treatment and they suffered unnecessarily. The good is that it forced us to be more precise. We learned that not all hormones are the same. Timing matters, route matters, and the type of progestogen really matters. That's why modern hormone therapy looks very different from what was tested in WHI. Okay, let's jump into who can use hormone therapy. Let's first talk about what the FDA officially approves hormone therapy for. The list is actually kind of short. Number one, treating hot flashes and night sweats. This is what we call vasomotor symptoms. Number two is treating genitourinary symptoms like vaginal dryness, pain with sex, urinary urgency. Number three is preventing osteoporosis in women at risk, which, if you ask me, is every woman in menopause. That's it. You'll notice that it does not say for preventing heart disease or for anti-aging or for dementia. Those uses are considered off-label, even though research shows hormones may have positive effects in those areas when started early. And that's it. You'll notice it does not say for preventing heart disease or for anti-aging or dementia. Those uses are considered off-label, even though research shows hormones may have positive effects in those areas when started early. What this means for you is just that just because the FDA didn't list something doesn't mean there's no benefit. It just means that that's not what they chose to give official approval for. Okay, now contraindications. When is hormone therapy not recommended? If you've had breast cancer or another estrogen sensitive cancer, if you've had a blood clot, DVT, or pulmonary embolism, if you've had a stroke, if you have liver disease, or if you have unexplained vaginal bleeding that hasn't been worked up yet. Notice this is a personal history and not a family history. So if your mom had breast cancer, this does not mean that you cannot use hormones. You may want to get genetic testing, but this does not exclude you. If you have any of these conditions, that doesn't mean hormones are off the table completely, but in these situations, the risks are higher and the conversation becomes more nuanced. So who's a good candidate for hormone therapy? If you're a woman struggling with menopausal symptoms like hot flashes, night sweats, sleep disturbances, brain fog, or weight gain, and you've ruled out any other condition that could cause these same symptoms like thyroid disease, diabetes, vitamin deficiencies, and so on, a lot of conditions have overlapping symptoms, so we can't assume everything is menopause related. Ideally, you want to start within 10 years of menopause. There's something called the timing hypothesis. Research shows that if you start hormone therapy within 10 years of your final period or before the age of 60, the benefits are strongest and the risks are lowest. That's the sweet spot. But what about women outside that window? Well, here's the nuance. For women who start hormone therapy after age 60 or more than 10 years past menopause, the benefit risk profile looks less favorable. Not because hormones suddenly become poison, but because things like heart disease, stroke, blood clots, and dementia are already more common at that age and may have already started developing. For women in their 70s and beyond, or more than 20 years past menopause, we honestly don't have good data. The WHI memory study, called WIMS for short, suggested more harm than benefit if oral hormones were started after the age of 65. But the key is that it was oral therapy only. We don't have strong randomized data about starting transdermal estradiol that late in life. On the flip side, when therapy was started earlier, near menopause, in women in their 50s, trials like ELITE and KEEPS found no cardiovascular harm and even some cardiovascular benefits. That's where the timing hypothesis comes from. So the bottom line is, if you're in your 40s or 50s and you're symptomatic, you're an excellent candidate. If you're outside that window, it doesn't mean no hormones. It means the conversation gets more individualized. We'd weigh your symptoms, your cardiovascular and clotting risk, family history, and even the route that you use, transdermal versus pill, before making a decision. And let's not forget, if you've had a hysterectomy, and especially if you've gone through surgical menopause or premature menopause before age 40, you're an even stronger candidate. In those cases, guidelines actually recommend hormone therapy unless there's a clear contraindication, because the long-term health risks of staying estrogen deficient for decades are significant. Okay, let's get into the different types of hormone options. But first, let me clear up this buzzword you may have heard of, bioidentical. You've probably seen it all over Instagram and wellness blogs, but here's the deal. Technically, bioidentical means the hormone molecule is identical to what your body makes. You may hear that synthetic is bad and you want to avoid synthetic, but the truth is all hormones are synthetic. They are all made in the lab. Even the bioidentical stuff that, like estrogen, is synthetically derived from yams. But in general, when people talk about synthetic hormones, they are referring to the type that are not molecularly the same as what your body makes. I just want to clear up that terminology here. We use umbrella terms like estrogen and progestogen when referring to all forms of synthetic and bioidentical. We use estradiol and progesterone for bioidentical. Then you'll hear the terms progestin. This refers to synthetic progesterone. But just know that some people, and even the studies, these are sometimes used interchangeably, as if it wasn't confusing enough. But for here, just know that if we are talking about progesterone and estradiol, we are talking about bioidentical. I hope that wasn't too confusing. Okay, next thing I want to touch on is that you don't have to go to a compounding pharmacy or somewhere special for bioidentical hormones. There are FDA-approved options right at your local pharmacy. That means they've been tested, studied, regulated, and we know exactly what's in each dose. Compounded formulations can also be an option, especially if you need something customized, like a very specific dose or a combination product. Or maybe you need progesterone, but you're allergic to peanuts. And micronized progesterone is made in peanut oil. But they aren't FDA approved, which means they don't go through the same rigorous testing for consistency and safety. Some women love them, some doctors use them, but the bulk of research is behind the FDA approved versions. So don't get swept away by the marketing. Bioidentical sounds nice and fancy, and yes, this is my preference, but you don't need to have fear. What matters is, are we using the safest, most effective option that's right for you? Remember, even in the WHI, the group that used the horse estrogen alone had great benefits. Even the women using the synthetic progestin had minimal increased risk compared to the rest of the population who weren't on hormones. Okay, now let's talk about options for estrogen. These are going to be bioidentical unless I tell you otherwise. There are oral estradiol, the classic pill. It works, but because it goes through your liver first, it has a small increased clotting risk and can elevate triglycerides. That's why many of us prefer to use non-oral routes, especially if you're older or have risk factors. If you do the pill, clotting risk has been shown to only be elevated in the first 6 to 12 months. Then it reduces back to baseline after. That means an extra 1 to 2 cases per 1,000 women. Transdermal estrogen patches, gels, sprays, these deliver estrogen directly into your bloodstream through your skin, bypassing the liver. That means there's lower risk of blood clots and stroke compared to oral. Local vaginal estrogen, this is the creams, tablets, rings. These stay mostly local in the vaginal tissue and urinary tract, perfect for dryness, pain with sex, or recurrent UTIs. And because absorption is minimal systemically, even women who can't take systemic estrogen because of cancer risk, clotting, or whatever else, often can use vaginal estrogen safely. Okay, progesterone. Just a quick recap. If you have a uterus, you need something to balance estrogen, so the uterine lining doesn't build up and put you at risk for uterine cancer. My first choice is micronized progesterone, 100 to 200 milligrams. It's bioidentical, FDA approved, and often helps with sleep. There's also vaginal progesterone, capsule, gel, suppository. These go directly into your uterus, so sometimes fewer systemic side effects. It's an option, especially for women who don't tolerate systemic progesterone. You can also use a Mirena IUD. Yes, you can use an IUD in menopause. It releases progestin locally, so it is synthetic, but it's another option to protect your uterus with minimal systemic effects. It's great for women who don't tolerate oral progesterone, don't want to do vaginal suppositories every day, and just want to set it and forget it. There are progesterone cream options, but these are not FDA approved. And the biggest reason that matters to me is that these have been studied rigorously and have been shown to be protective of the uterus. If you don't have a uterus and you are using progesterone for the other benefits, then we can talk about alternatives. This also might be an option if you are in perimenopause. Even if you don't have a uterus, I do prefer that you be on progesterone if you are on estrogen because estrogen is proliferative. It promotes growth. Progesterone is anti-proliferative, basically balancing out estrogen's effects. So I feel it may provide some more protection. Okay, let's talk about testosterone. Testosterone supports energy, motivation, muscle mass, and yes, libido. In the US, the FDA only approves testosterone for the indication of hypoactive sexual desire disorder. So most prescribers use it off-label for women with low desire, low energy, or muscle loss because it can make a huge difference. There's no FDA-approved testosterone product specifically for women, so most women use it as a low-dose cream or gel. If you know any men using gel, our dose as women is about a tenth of what they use. So I prefer to get this compounded because then you can get a more precise dose rather than using a male's prescription and try to guess your dose. Pills we generally stay away from because of side effects and risks. Some people use troches, which dissolve in your mouth, but you really have to be diligent about not chewing it and swallowing it. You may have heard of hormone pellets, tiny implants placed under the skin every few months, or injections. Some women love the convenience because you don't have to remember a cream. But here's my take. The downside is that pellets and injections can give you a very high, non-physiological hormone level, especially with testosterone. Once the pellet is in, you can't take it out. If the dose is too high, you're stuck waiting it out for 3 to 4 months. There are side effects that from like high testosterone, like acne, hair growth on your chin, male pattern baldness, voice changes, and some of these things may not fully reverse. I find that most women who are using injections or pellets end up with very high levels of testosterone. It's not that pellets or injections are bad, but they're less flexible and harder to fine tune. I usually prefer forms that let us adjust more easily and that are closer to our true physiology. But again, this is very individualized. Okay, let's talk about the myths that I hear commonly. Myth number one, estrogen causes breast cancer. Okay, I don't need to beat a dead horse, and I hope that if there's anything you take away from this video is that estrogen does not cause cancer. We went over where that rumor came from with the WHI and know that it actually has shown to reduce risk. If you want to know the causes of breast cancer, it's on this list. Cancer is multifactorial, as we know. There is not one cause. Myth number two, You have to wait until you're in menopause to start HRT. This one really frustrates me because so many women suffer in silence, thinking, I'm not technically in menopause yet, so I can't do anything. But that's not true. Perimenopause is often when symptoms are worse. Cycles are heavy or irregular, sleep falls apart, anxiety shows up out of nowhere, hot flashes are creeping in. Hormone therapy can absolutely be used in perimenopause to smooth the ride. Some doctors prescribe birth control pills to women in their 40s to manage this, but those are high dose synthetic hormones. If you're trying to avoid pregnancy, then that makes sense. But for women, low dose bioidentical estradiol plus micronized progesterone is a gentler, more physiological option. Managing perimenopause is definitely more challenging, but there are absolutely options. So, no, you don't have to wait until your period disappears for 12 months. The best time to start is when your symptoms are disrupting your life. Myth number 3, you have to stop hormones at age 60 or 65. I hear this one constantly and it keeps women suffering. Here's the truth, there is no magic age where your hormone therapy suddenly becomes unsafe. The old idea was that the shortest duration, lowest dose stopped by 65. But newer guidelines say that the decision should be individualized. If you're healthy and still benefiting, sleeping better, protecting your bones, having energy, why would you rip that away at 65 just because of a birthday? Myth number 4, hormones will make me gain weight. Oh, this one. So many women tell me, I don't want to start hormones because I'm already gaining weight and I don't want it to get worse. Here's the truth. Weight gain in midlife is largely due to the drop in estrogen, not taking estrogen. When estrogen falls, we lose muscle, metabolism slows down, and fat redistributes into the belly. That's why many women notice that their body shape changes from pear shape to apple shape, even if they're eating and exercising the same way. In the WHI, women who were on estrogen gained less weight and the incidence of type 2 diabetes compared to the rest of the population. Estrogen therapy doesn't cause weight gain. In fact, it can help prevent that shift towards belly fat and metabolic syndrome. So, if anything, hormones may actually protect your metabolism. Myth number 5, hormone therapy and birth control are the same thing. This is another big misconception. Birth control pills are high dose synthetic hormones meant to shut off your ovulation. Menopause hormone therapy is usually lower dose, often bioidentical, and meant to replace what your body no longer makes. Totally different goals, doses, and outcomes. Saying birth control and HRT are the same is like saying a fire hose and a garden hose are the same because they both spray water. Yes, but they're built for completely different purposes. Myth number 6, only women with a uterus who are taking estrogen can benefit from progesterone. Nope, you can take micronized progesterone at any age, whether or not you take estrogen. You can take it even if you don't have a uterus. Many women find benefit with sleep and anxiety. Many of my patients with hysterectomies also take progesterone. We don't have as much data on micronized progesterone, but we don't see an increased risk of breast cancer or clotting with it. Myth number 7, I'm too old to take hormone therapy. Listen, when it comes to deciding on use of hormones, it is often a shared decision here. Since the WHI, there was a whole generation of women who were wrongfully never offered HRT. Today, we tailor that therapy to the individual, your symptoms, your risks, and your goals. The fact of the matter is, we may have limited data on a lot of things in women's health, so discussing the data we do have available and what we don't have is really important. Many women understand that some of what the research may not be done in their lifetime. So this is very individualized conversation. Here's what the evidence actually says. The most favorable time to start HRT is before age 60 or within 10 years of menopause. That's when the benefits of symptom relief, bone protection, metabolic improvements outweigh the risk most clearly. If you start after 10 years post-menopause or after age 60, the profile isn't as clearly beneficial. It's not that hormones suddenly become dangerous, but they also don't seem to offer the same heart or brain protection. At this stage, the effects looks more neutral, with some possible increase in stroke risk depending on the individual and the route of administration. When therapy is started 20 years past menopause or after the age of 70, studies suggest that the risk may actually outweigh the benefit. In the WIM study, women over 65 who started oral estrogen plus or minus progestin had a higher risk of stroke and dementia. Remember, this study was on oral equine estrogen. We have observational studies that showed transdermal estradiol, like patches or gels, that don't appear to increase clotting risk, but starting therapy with transdermal is limited. Some providers might order a coronary calcium score, check blood pressure and cholesterol, or weigh in other health risks before deciding. For some women, improving quality of life is worth the potential risks. For others, it's not. So the bottom line is you're not automatically too old. The later you start, the more careful the discussion needs to be. Okay, this is a long one, but I hope it was informative. So thanks for hanging in there. See you in the next one.